Okay, then moving on to our chosen abstract submitted for the symposium today. So it's my pleasure to introduce Joseph Lerman, who's actually a medical student at Mount Sinai, who's doing research work in Dr. Mehta's group at NHLBI, the National Institutes of Health in Bethesda. So he's going to talk today about his work on PET-CT and psoriasis, and his talk is entitled Lack of Improvement in Aortic Vascular Inflammation is Associated with an Increase in Coronary Plaque Burden in Psoriasis.
Perfect. So thank you very much. It's a real pleasure to be here. As Dr. Robson said, I'm a medical student here at Mount Sinai, though currently I'm on research fellowship at the National Heart, Lung, and Blood Institute in the lab of Dr. Nehal Mehta in the section of inflammation and cardiometabolic diseases. And our project is titled Lack of Improvement in Aortic Vascular Inflammation is Associated with an Increase in Coronary Plaque Burden in Psoriasis. No disclosures, though I did recently have to pay next semester's med school tuition, so some disclosures might be appreciated to offset that. These are objectives of my talk. I think Dr. Lee actually said it much better than I can, but though atherosclerosis was once thought of as a passive process mediated by almost static deposition of lipids within the arterial wall, we now know that from initial endothelial cell dysfunction to intermediate monocyte macrophage accumulation and ultimate atherosclerotic plaque rupture, this is a process that's driven forward by innate immune mediators and inflammatory cytokines. And psoriasis provides our lab with an ideal clinical human model to study innate immunity and inflammation in atherogenesis. Why? Well, it's a common disease. It occurs in around 2 to 4% of the US population. It has a waxing and waning course, which is characterized by innate immune activity and the upregulation of pro-atherogenic cytokines. And it's associated with accelerated atherosclerosis and early and increased cardiovascular disease. And epidemiology really supports psoriasis as a model of accelerated atherosclerosis. So this is population-level data here. And you'll note your psoriasis patients are in blue. The rest of the population, your controls, are in red. And you'll see that from early adulthood throughout the life cycle, the percent of patients with cardiovascular disease is significantly increased in our psoriatics. And this is beyond adjustment for many other cardiometabolic variables which associate with psoriasis. In fact, patients with severe psoriasis have a 57% increased risk for cardiovascular death and a 58% increased risk of myocardial infarction. And so in our lab, we try and study subclinical atherosclerosis and inflammation in these inflammatory patients before these events occur. And how we do that is we use multimodal imaging. So we use FDG PET-CT, which just allows us to estimate the inflammatory burden of this disease in the aortic wall. But as we always talk about in our cohort, you have to go where the money is. And these myocardial infarctions aren't happening in the aorta, they're happening in the coronaries. So while I'd love to say that we can do a three-dimensional coronary MRI like Dr. Lee is doing, we actually use coronary CT angiography, which nevertheless does a nice job of phenotyping and quantifying coronary plaque burden in these patients. So briefly, this is how our FDG PET-CT protocol works. Just as in cancer imaging, many of you are aware, our radiolabeled glucose analog is taken up by metabolically active cells. In cancer, that corresponds to your tumor, and in inflammatory disease and inflammatory atherogenesis, that corresponds with your monocyte macrophage active inflammatory signal within the aortic wall. So using a dedicated PET-CT workstation, we are able to contour regions of interest throughout the entire thoracic aorta. We can subsequently quantify the standardized uptake value or the amount of FDG uptake within each of these regions of interest. But to really hone in on the FDG uptake within the aortic wall, we subsequently divide that SUV by the background blood pool activity of FDG, which is measured in the vena cava. That provides you with a target to background ratio, which is subsequently averaged out through each region of interest across the aorta, which gives us an average TBR, which is what I'll be reporting on for the rest of this talk. So on our left panel, we see PET images in psoriasis versus controls, and we've previously shown that vascular inflammation is elevated in our psoriatic patients. On your PET image here, you'll note increased tracer uptake in the skin, in the joints. It's interesting, this patient actually at the time of scan had no joint symptoms, but subsequently months after was clinically diagnosed with psoriatic arthritis. So this is representative of early inflammatory activity within the joint space. And you also note increased PET uptake within the vasculature of the lower extremities. And in our sagittal cuts, PET activity in the aorta and the carotids, but it's really driven home by our differences in these axial slices of the aortic arch. So why is this important? Well, the more severe your psoriasis is, as measured on your x-axis here, this is a clinical research psoriasis severity score. On the y-axis is your aortic target to background ratio, so that estimate of your aortic inflammatory activity. These two things are highly correlated. And really, thinking back on our epidemiology, this is important because aortic vascular inflammation by FDG PET-CT is highly associated with cardiovascular death, myocardial infarction, and other cardiovascular events. So this is work from Dr. Talcall's group at the MGH. They took a large cohort of patients who had had PET-CT. They followed them prospectively, and you'll see here are tertiles of target to background ratio. So these are the patients with the lowest amounts of aortic inflammation, and this is the tertile of the highest aortic inflammation, and you'll note the drastic increase in relative risk for major adverse cardiac event in this highest, most inflamed group. So that really brought us to our research question. Thinking about that longitudinal relationship between specifically myocardial infarction and aortic vascular inflammation by FDG PET-CT, we wanted to know what the short-term longitudinal relationship was between vascular inflammation of the aorta and coronary disease progression. And as I said before, we use coronary CT angiography to longitudinally phenotype plaque burden in the coronaries of these patients. So we use a second-generation wide-volume 320 detector row scanner. It's an ECG-gated protocol. Everyone's on a radiation conserve protocol as well, so this is sub-millisievert radiation exposure. And using semi-automated quantifiable software, we can create these multiplanar reconstructions of the coronaries, where we're subsequently able to delineate between the outer vessel wall and the lumen, and subsequently define a plaque space, as you can see circumscribing this calcified plaque from our cohort, but also several smaller non-calcified plaques throughout the vessel. And based on a schema that's roughly approximating what I'm showing you here, that allows us to create a total plaque volume index for across the major segments of the coronaries. And these have been associated by other groups with prospective cardiovascular death. And we can do this for both the total amount of plaque burden, but also the non-calcified plaque burden. And I'll be focusing on non-calcified burden for the rest of this talk, as that is one most associated with inflammatory stimuli, but also most associated with culprit lesions in myocardial infarctions. So our hypothesis was that an improvement in vascular inflammation by FDG PET-CT might associate with a delayed or an absence of progression in coronary plaque burden, specifically non-calcified coronary plaque burden in our psoriasis patients. And to answer this question, 67 psoriasis patients were recruited to the NIH as part of an ongoing cohort study. They were seen at baseline and one-year follow-up, where they had physical exam, deep cardiometabolic and immune phenotyping, and they had same-day coronary CT angiography and FDG PET-CT. And for data analysis purposes, we split the cohort into two subgroups: those whose aortic vascular inflammation improved from baseline to 1 year, and those whose progressed. And so these are the results of what those two groups looked like. You'll note similar baseline age and gender distribution. However, the group whose vascular inflammation got worse over the study period had a significant increase in both body mass index and insulin resistance. These groups had very similar psoriasis severity scores at baseline. However, the group whose vascular inflammation improved had a significantly increased uptake in systemic or biologic psoriatic treatments across the study period. So these include things like low-dose methotrexate, anti-TNF, or monoclonal antibodies to various inflammatory cytokines. The differences in these cohorts, so those who had an exacerbation in their aortic vascular inflammation, it was around an 11% increase of that target to background ratio. And those who had an improvement in vascular inflammation, it was around an 11% decrease. And just to put this decrease in context, Dr. Taukal's group also published or has published on the effect of statins on FDG uptake. And an 11% increase is significantly greater than that seen even, or 11% decrease, I should say, is actually a significantly larger decrease than that would be seen with low-dose statin therapy. And so this is how these two signals related to each other at baseline. Those patients with highest target to background ratio had highest amount of non-calcified plaque burden. And there was a highly significant statistical relationship between these two measurements. So those patients with the most inflamed aorta had the most involvement of non-calcified coronary plaque beyond adjustment for Framingham risk score and many other traditional cardiovascular risk factors. So given this tight baseline association between aortic vascular inflammation and coronary plaque burden, it perhaps is unsurprising that in those patients who had a significant increase in their vascular inflammation from baseline to 1-year follow-up, there was a significant increase in both total but also non-calcified coronary plaque. And conversely, in those patients who had an 11% decrease in their target to background ratio of the aorta, there was a near stabilization in the progression of their total and non-calcified coronary plaque burden. Again, this was a highly related statistical relationship. So on the x-axis here, this is our change in aortic target to background ratio amongst those patients who had a progression or a worsening of their aortic target to background ratio. And you can see that those patients who had the largest increase in vascular inflammation were the same patients who had the largest increase in coronary non-calcified burden. And this relationship also persisted beyond Framingham risk score, statin, body mass index, systemic biologic therapy, and many other variables, as can be noted in our regression table. So there are some limitations to this study. To begin, unlike Dr. Taukal's group, which followed patients for 6 years and had hard cardiovascular endpoints, we're working with 2 surrogates for subclinical coronary disease or subclinical athero. But we would argue that these are surrogates which have been highly validated with prospective cardiovascular events. And we would also argue that from a preventative standpoint, what we really are trying to understand is the role of inflammation on subclinical disease. Additionally, this is an observational study design. This was not an interventional study. However, all of the interventions that occur within our patients over the study period are highly recorded and adjusted for in a systematized database at the NIH. And obviously, we are continuing to enroll and grow our sample size. But that said, in conclusion, a worsening in vascular inflammation by FDG PET-CT is associated with an increase in both total, but especially non-calcified coronary plaque burden. This is contrasted by the fact that an improvement in vascular inflammation may associate with the stabilization of total and non-calcified coronary plaques. We believe that this data is suggestive that changes in aortic vascular inflammation may be approximated or may approximate the progression of non-calcified coronary plaques. We believe these results lend insight and are consistent to the known association between vascular inflammation and prospective cardiovascular events. And we believe they suggest that a change in aortic vascular inflammation by FDG PET-CT may perhaps be seen as a surrogate marker for coronary disease progression. So I'd like to thank my mentor, Dr. Mehta, our collaborators at the NIH, including Dr. David Blumke, Dr. Marcus Chen, and Dr. Veit Sanford, who are really critical in the image acquisition for this protocol. I'd also like to thank the Medical Research Scholars Program. I'd also like to extend an invitation to you all to the imaging, vascular inflammation imaging conference at the NIH in October. Dr. Mehta was walking around looking at a lot of the posters and hoping that many of you will submit. Thank you, and I'd be happy to take any questions.
Thanks very much. There's some really interesting results there. Any questions from the floor, Zeiss?
Just a pretty simple question. On your measurement on CT with CTA for coronary, do you have reproducibility study on plaque burden measurement, either for the total burden or the non-calcified plaque?
Yeah, so we have done reproducibility studies. We are highly reproducible. I don't want to misquote our percentage correlation, but it's something near 92% inter patient.
It's a very nice study. I was just wondering which way round you think things are happening. Do you think that the inflammation is causing increased plaque progression, or do you think the fact that you've got more plaque means that you've got a higher inflammation signal?
So that's a great question. So I think the directionality of the relationship suggests that it's inflammation driving the progression of plaque, though certainly the signal that's captured by FDG PET-CT is representative of many different atherogenic stimuli, certainly not just the psoriatic disease severity. So it could actually be either way. I don't know if this study is able to answer that.
Well, I guess if you looked at the baseline PET data and looked at whether that predicted progression in the plaque assessments, then that might work. You might be able to tease that out then.
Mm-hmm. Yeah, certainly, and that's something we will be looking at as this cohort continues to enroll.
So, a very nice talk. Don't you think that you maybe also just treating plaque inflammation, for example, with these TNF-alpha inhibitors or methotrexate, that the drugs themselves have effect on plaque inflammation and therefore your FDG signal?
So that is a highly relevant question, especially given the enrollments in the CERT and the CANTOS trials. We do believe that systemic biologic therapies are treating both the plaque inflammation itself, but also the pro-atherogenic inflammatory phenotype of the patient beyond what's happening merely in the signal that's captured on the PET scan. And there's probably a whole other talk that could be given on that. But I guess that's the best I can answer that, yeah.
Yeah, it's pretty interesting, right? Because it would also allow you to kind of, like some secondary study to evaluate the effects of these kind of therapies on atherosclerosis.
Yeah, and
which is not, I don't know, maybe Zahi knows more about it.
So Willem, we have actually done a biologics study in psoriatic patients. So the study, we haven't published this yet, was negative because the drug was not actually effective in reducing the PASI score or reducing plaque inflammation. But it is definitely the right setting that these diseases are also very much useful in terms of understanding mechanistically what's going on in atherosclerosis and also the treatment. And we are, as you know, doing part of a multi-center trial to look at the effect of low-dose methotrexate, which is an RA drug used in now being tested for events reduction in cardiovascular patients. Yeah.
Thank you.
One more question.
In those patients where you had the insulin resistance, please, I don't need the photograph. Did you also find or subdivide that particular set of patients into treated or non-treated for their underlying diabetes or metabolic syndrome? So you didn't identify whether or not these patients were being simultaneously treated not only for the psoriasis, but for the comorbidities that you also stated there.
Yes, so we do deep phenotyping on these patients, and we do also adjust for diabetic therapy, lipid therapy, inflammatory therapies. So all of that information is captured in the adjustment models that I showed.
Okay, because the question was, for example, if in fact there's a modulation of the insulin resistance, whether that could have also had an impact on the overall outcomes in both aortic data and the coronary data.
So whether or not increased insulin resistance is driving both coronary plaque, but also the increase in FDG signal that we might be seeing?
Because I think some of this data is also pretty reminiscent or similar to data that's been discovered in non-insulin dependent diabetics, individuals that don't have any history of psoriasis. Even though this is a very, very good model, those patients also have accelerated atherosclerosis and aortic inflammation and involvement of both the aorta and the coronary arteries. So I'm just curious whether or not, if you, in fact, you can compare your data to the data of non-insulin dependent diabetics, type 2 diabetic patients, see whether or not there's some correlations, and then try to tease. I know it's difficult because clearly the pathogenesis of psoriasis has obviously been very well defined and continues to be well defined. There may be some type of an overlap, and then maybe there may be some important data that to be extracted, and then perhaps, I know you controlled, but the question is, how many of these patients in your cohort had actual non-insulin resistance demonstrated? Was that the majority of those subjects or not?
There's certainly a high epidemiologic prevalence.
There is, but
it's around 15% of both of these arms have type 2 diabetes
about
diagnosed.
15.
Yeah,
Okay.
15%.
I would then maybe subdivide it, concentrate one group cohort with the type 2 diabetes and the insulin resistance compared to the remainder that do not have that, and then see whether the data fluctuates.
Certainly. And we've done a similar analysis as you're suggesting for this data in a much larger sample size that we published in the European Heart Journal. But it's certainly worth looking at for us. Thanks.
We need more sample size
Yeah.
here to do further analysis.
All right. Okay, so thanks very much.
Yeah, thank you.
Great talk. You guys.